Lesson 9. Why schizophrenia rarely appears on its own. Schizophrenia is very rarely the only health problem a person is dealing with. In clinical practice and in caregivers' experience, it almost always turns out that alongside the psychotic illness there are other disorders or diseases that affect treatment, daily functioning, and long-term prognosis. Understanding this fact is one of the key elements of good care. Without it, it is easy to fall into the trap of simplifying everything down to one sentence. It's because of the schizophrenia, which often leads to mistakes, neglect, and unnecessary suffering for the person. Some health problems arise directly from schizophrenia itself or from its treatment. These include, among others, post-psychotic depression, heightened anxiety, addictions, extrapyramidal symptoms, and metabolic disorders caused by long-term use of antipsychotics. These difficulties are, in a sense, built into the course of the illness and require constant monitoring and cooperation with the psychiatrist. For the caregiver, this means being able to recognize whether new symptoms represent a relapse of psychosis, a side effect of medication, or a separate problem requiring a different kind of support. At the same time, people living with schizophrenia can also develop conditions completely unrelated to mental disorder, the same ones that affect healthy people. High blood pressure, heart disease, diabetes, thyroid disorders, neurological diseases, or age-related conditions can appear at any point in life and significantly complicate psychiatric treatment. The difficulty is that the symptoms of such illnesses are often mistakenly interpreted as the patient's behavior or another symptom of schizophrenia, which means real physical risks may be missed. Good care for a person with schizophrenia starts from the awareness that we are not dealing with one illness, but with an entire tangle of biological, psychological, and somatic processes. The better you understand this tangle, the greater the chance of stability for the person in your care and a real reduction in their suffering. Disorders and conditions directly related to schizophrenia. When you enter the world of schizophrenia as a caregiver, you quickly notice that this illness almost never appears alone. In psychiatry, it is increasingly emphasized that schizophrenia is not one simple entity, but a broad syndrome of disturbances. It has many faces and many speeds. For one person, psychotic symptoms dominate; for another, slowing and apathy; for yet another, chronic tension and anxiety. This variability in the very picture of schizophrenia means the illness easily interacts with other difficulties. And that is precisely why it is so important to understand not only what schizophrenia is, but also what it is capable of imitating. Schizophrenia affects thinking, emotions, day-to-day organization, and the way the person experiences the world. It shapes how they respond to pain, fatigue, stress, or physical illness. A simple stomachache may be described as anxiety, and anxiety as a vague sense of threat. Simple weakness may look like depression, and neurological symptoms like recurrent psychosis. In turn, medication side effects can easily be misread as symptoms of the illness itself. These overlapping layers make it easy to miss something important. Most often, once the psychotic symptoms have subsided, depression appears. This phenomenon is described in many textbooks and is clearly seen in clinical practice. The person begins to see themselves and their life without the distortions of psychosis, and this is not always an easy experience. They are hit by a sense of loss, shame, guilt. Deep sadness and hopelessness may appear. You may see someone sleepy, withdrawn, reluctant to act. In reality, this may be depression, not just apathy. And depression in schizophrenia has one particularly dangerous feature. It is a time when the risk of suicide often increases. This is why it demands vigilance. Another very common co-occurring problem is anxiety. Anxiety in schizophrenia does not have to look like an anxiety disorder in an otherwise healthy person. It may be described as tension, unease, or a feeling that something bad will happen. Sometimes the person cannot distinguish anxiety from their delusional thoughts. Anxiety can make them afraid to leave the house, avoid people, shut themselves away, and their body reacts as if overloaded. From the outside, this can look like negative symptoms of schizophrenia, even though it is something completely different. You see someone who doesn't want to cooperate. They are experiencing a state that can paralyze them within minutes. Addictions are another frequent problem. Many people try to regulate their tension and emotions with alcohol, marijuana, tranquilizers, or cigarettes. You might not even notice this because against the background of schizophrenia, using substances can easily look like simple or blowing off steam. Unfortunately, psychoactive substances disrupt the effects of medication, increase relapse risk, and deepen mood disturbances. In practice, this means that even occasional drinking or smoking can undermine the stability that has taken months to build. Metabolic problems caused by medication are also common. Antipsychotics can alter glucose metabolism, increase appetite, lower energy, and cause sleepiness. The person gets tired more easily, gains weight, and functions more slowly physically. If you don't monitor this, diabetes, hypertension, or lipid disorders may develop. In the consulting room, the doctor sees the patient for a few minutes. You see them all day and are often the first to notice that something is changing. A separate issue are movement-related side effects, stiffness, tremors, slowing, or, conversely, an inner restlessness and compulsion to move that the person cannot describe. This is not their psyche, but the nervous system reacting to the drug. Such a picture is easily confused with poor mental state or growing aggression. In reality, it may be drug-induced Parkinsonism or akathisia, which require adjusting the medication. All these disturbances create a second layer of schizophrenia. They are not its essence, but they are its frequent companions. And you, as a caregiver, are the first to see them. If you understand their nature, you can genuinely help distinguish what stems from the illness itself, what from its treatment, and what from an additional condition that happens to be overlapping the overall picture. Co-occurring illnesses independent of schizophrenia. In clinical practice, we clearly see that physical and neurological diseases are more common among people with schizophrenia than in the general population, not because schizophrenia directly causes them, but because day-to-day functioning, lifestyle, poorer access to diagnostics, and the effects of medication together raise the risk of many illnesses. If you are a caregiver, you need to know that your loved one may have more than one condition, and that physical symptoms often look different in them than in a healthy person. According to WHO data, people with schizophrenia die on average 10 to 20 years earlier than the general population. This is a depressing fact, but also a very important one. Most of these deaths are not caused by schizophrenia itself. The main causes are cardiovascular diseases, diabetes, lung diseases, chronic infections, and untreated neurological disorders. This means that proper attention to physical health can genuinely prolong and improve the person's life. Cardiovascular diseases. Hypertension, coronary artery disease, and heart rhythm disturbances occur in people with schizophrenia more often than in the general population. Statistics show that the risk of stroke and heart attack is about 30 to 50% higher. This does not result solely from medication effects. Significant roles are played by lack of physical activity, unhealthy diet, smoking, very common in schizophrenia, difficulty in regularly monitoring blood pressure and cholesterol, diagnostic delays, the person reports chest pain or breathlessness vaguely, or attributes them to feeling bad mentally. If your loved one complains of chest pressure, shortness of breath, dizziness, or swelling of the legs, you cannot treat this as a symptom of mental illness. These may be signs of a serious heart condition that requires immediate investigation. Medical literature stresses that caregivers are often the only ones who pick up these signals. Neurological and neurodegenerative diseases. Stroke, epileptic seizures, neurological disorders, and dementia are further problems that can overlap with schizophrenia. Statistically, in people with a diagnosis of schizophrenia, the risk of stroke is higher and recovery to full function is more difficult. The causes lie in metabolic factors, lower physical activity, and difficulty in responding quickly to the first symptoms. Neurological symptoms can closely resemble a worsening of psychosis. Balance problems, speech difficulties, slowing, or disorientation are easily taken for recurrent confusion. However, if you notice that the person suddenly moves differently, has facial asymmetry, slurred speech, or weakness on one side of the body, you must react as you would with anyone else. These may be signs of stroke. In schizophrenia, such signals are often mistakenly downplayed, which leads to tragic consequences. Everyday physical illnesses. Thyroid disorders, asthma, COPD, chronic joint pain, inflammation, infections, kidney disease. All of these occur in people with schizophrenia just as they do in everyone else. The difference is that someone with schizophrenia often describes their symptoms differently. They might say they feel restless instead of "my stomach hurts." They might interpret shortness of breath as tension and chronic pain as mental exhaustion. Because of this, even family doctors sometimes wrongly assign all complaints to psychiatry. If you notice changes in energy level, breathing difficulties, chronic fatigue, sudden sleepiness, or persistent pain in your loved one, do not explain everything with schizophrenia. In clinical practice, it is repeatedly shown that most serious illnesses in psychiatric patients are missed precisely because everything was interpreted as a mental disorder. Aging with a diagnosis of schizophrenia. If your loved one is 60 plus, you need to know that aging with schizophrenia looks different than aging in otherwise healthy people. Hearing and vision deterioration, reduced mobility, poorer coordination, muscle weakness, these elements of aging are layered over negative symptoms. As a result, the person may seem more withdrawn, apathetic, or confused, when in reality they are struggling with typical age-related conditions. Statistically, the risk of dementia in people with schizophrenia is about twice as high. Yet dementia symptoms can easily be confused with negative symptoms or drug-induced slowing. For this reason, any sudden changes in memory, orientation, or clarity of thought should be evaluated neurologically. Not everything in older age has to be schizophrenia. Symptom overlap. If you care for someone with schizophrenia, you will quickly see that symptoms of various illnesses do not fall into separate, easily labeled drawers. What looks like mental deterioration may be a medication side effect. What looks like depression may stem from diabetes, hyperthyroidism, or chronic pain. And what looks like delusional anxiety may be a sign of a rapidly developing infection. In medicine, we call this symptom interference, symptoms stacking and distorting each other. In people with schizophrenia, this phenomenon is particularly frequent. Not because the body works differently, but because the picture of mental illness can overshadow all other ailments. Caregiver guides repeatedly stress that the most common cause of serious complications in these patients is precisely the mistaken attribution of all symptoms to psychiatry when their source lies somewhere else entirely. One of the most common problems is slowing. The person starts to walk, speak, and react more slowly. To an outside observer, this may look like worsening schizophrenia, but in reality, slowing can have several sources. It may stem from negative symptoms, but it can also be a side effect of medication, the beginning of depression, a sign of hyperthyroidism, the start of an infection, dehydration, or a manifestation of drug-induced Parkinsonism. In clinical practice, we often see caregivers and doctors treating psychotic exacerbation for weeks, when the real problem is an excessively high dose of medication or an untreated physical illness. The same is true for insomnia. Nighttime wakefulness may look like a sign of psychotic relapse, and sometimes it is, but just as often it results from anxiety, physical pain, medication side effects, metabolic disturbances, or very mundane factors: too much strong coffee, lack of evening wind down, nicotine withdrawal, or alcohol use. NICE guidelines emphasize that insomnia should always be assessed from multiple angles, because ignoring its root causes leads quickly to deterioration in functioning. Neurological symptoms are another frequent source of confusion. Slurred speech, balance problems, and concentration difficulties can look like strange psychotic behavior. In practice, they may be early signs of stroke, epilepsy, dehydration, low sodium, or a neuroleptic side effect. Hospitals have repeatedly documented situations where neurological symptoms in psychiatric patients were wrongly labeled as behavioral disturbances, delaying treatment by hours. Similar mechanisms appear with mood disturbances. The person begins to complain that they have no strength, that they don't want to live, that everything is pointless. This may be depression, but it may just as well be diabetes, anemia, dehydration, physical pain, or a recent medication change. Population studies show that people with schizophrenia have more than twice the risk of depression, but in many of them the symptoms are driven by other, non-psychiatric causes. For this reason, one of the most important elements of care is avoiding the trap of a single explanation. If you see a change in behavior, mood, or energy, do not automatically assume that schizophrenia is flaring up. In psychiatry, it has long been emphasized that every sudden change in symptoms should first be treated as a possible physical symptom, and only then as a mental deterioration. This is the principle used in good clinical centers. First we rule out illnesses of the body, then we address the mind. To make this easier, many specialists recommend keeping a simple observation notebook. Write down symptoms, dates, circumstances, medications, sleep patterns, eating, unusual behaviors. It is precisely these notes that allow the doctor to separate which symptoms stem from psychosis, which from depression or anxiety, and which from diabetes, heart problems, or medication side effects. Studies have shown that patients whose caregivers keep notes have fewer hospitalizations and better symptom control because changes are detected earlier. The hardest part of caring for someone with schizophrenia is that physical and mental symptoms constantly mask each other. However, if you are aware of this dynamic and observe the person attentively, over time you will learn to recognize subtle differences. And it is this attentiveness, not theoretical medical knowledge, that truly reduces the risk of complications and sudden crises. Pharmacological conflicts and difficulties in treatment. Treating a person with schizophrenia is very rarely simple and linear. It usually requires combining many medications, and each of these substances affects how the others work. This is precisely why people living with schizophrenia are particularly exposed to pharmacological conflicts. This does not happen because of the strength of psychiatric drugs, but because the person's body functions in a delicate balance, influenced both by pharmacotherapy and by physical illnesses, lifestyle, smoking, and the way medications are metabolized. Interactions between medications are one of the most common clinical problems. Antipsychotic drugs can affect the action of medications used for heart disease, diabetes, lipid disorders, or neurological conditions. Conversely, some physical health medications can increase antipsychotic levels or weaken them, leading to sedation, fainting, heart rhythm disturbances, agitation, or an apparent relapse of psychosis. Medical literature repeatedly reminds us that heart rhythm disturbances may appear when a QT prolonging drug is combined with another medication acting in a similar way. Likewise, drops in blood pressure intensify when an antipsychotic is combined with an antihypertensive. Sedation becomes dangerous when benzodiazepines, opioids, or strong sleeping pills are added to antipsychotic treatment. Smoking, extremely common in schizophrenia, changes the rate at which some antipsychotics are metabolized, causing them to stop working as they should. As a result, symptoms may return not because the drug is failing, but because nicotine speeds up its breakdown. In clinical practice, an additional difficulty arises from treatment by multiple specialists. The psychiatrist, cardiologist, diabetologist, and family doctor each focus on their own area and often do not have a full picture of the overall medication regimen. You, on the other hand, see the whole picture, and it is precisely your observations that can protect the person from a dangerous interaction. This is why it is so important that all medication changes are written down and communicated to every doctor involved in treatment. Even one-off medications such as antibiotics, painkillers, or calming agents can affect the action of psychiatric drugs, so nothing should be omitted or dismissed as unimportant. Sometimes treatment needs to be modified not because the medication stopped working, but because the person's body begins to react to them in an unfavorable way. Weight gain, increasing fatigue, problems with glucose or cholesterol, motor restlessness, tremors, muscle stiffness, concentration difficulties, or excessive sleepiness can all signal to the doctor that it is time to change the drug or adjust the dose. In many cases, it is the caregiver who first notices these subtle changes. Medical literature emphasizes that family observations are not only helpful but actually crucial, because you see the person continuously, not just in the brief snapshot of an office visit. Psychiatric treatment becomes even more difficult when the person does not take medications regularly or adjusts doses on their own. Even occasional missed doses can lead to fluctuations in blood levels and cause sudden deterioration in mental state. Conversations with the doctor then become less effective because psychiatrists are unable to distinguish whether the worsening is due to the illness itself or to irregular medication use. This is exactly why honesty from both the person and the caregiver, and giving the doctor full, truthful information about daily functioning and actual medication use is so important. Pharmacological conflicts are not something you can avoid completely, but they are something you can effectively manage. The better you understand how the medications work, the more carefully you observe the person's reactions, and the better you communicate with doctors, the lower the risk of crises. Your role is not to replace specialists, but to tie all the elements of therapy together into a coherent whole. It is this integration, your attentiveness and ongoing observation, that most often determines the person's safety and stability. How to support the person when there are co-occurring illnesses. Your role as a caregiver is not to diagnose illnesses or replace doctors. It is to observe carefully and to join together what different specialists are seeing. In practice, it is you who has the best chance to notice that something is beginning to change. Co-occurring illnesses rarely appear suddenly and in an obvious way. More often they start with small signs: a drop in energy, sleep problems, increasing irritability, appetite changes, new pain complaints, or worrying weight loss or gain. If you can pick up on these signals, you react faster than any medical system. Many medical guides for caregivers emphasize the value of keeping a simple observation diary. This is not about writing medical reports, but about noting real changes, the sort that from the outside might look insignificant. Writing down the date, new complaints, reactions to a medication, or a sudden mood drop later allows the doctor to reconstruct the sequence of events. In psychiatric clinics, we often see that patients whose families keep such notes are admitted to hospital less often and respond more quickly to health changes. Regular monitoring of physical health is just as important as psychiatric treatment. Antipsychotics can affect the heart, metabolism, and muscle tone, so periodic tests are necessary: glucose, cholesterol, blood pressure, ECG, and sometimes liver function or electrolyte levels. The person will not keep track of this on their own, because disturbances in attention, motivation, and day-to-day organization are part of the illness. You are the one who can keep track of dates, remind them about appointments, and ensure that test results reach the appropriate specialist. In daily life, lifestyle plays a huge role. You do not need to create complicated plans. It is enough to encourage moderate physical activity, maintain regular meal times, limit sweets and fats, ensure proper hydration, and above all, talk about avoiding substances. Alcohol, Marijuana, cigarettes, or tranquilizers borrowed from a friend very quickly destabilize the person's condition and interact with their medication. If the person smokes, remember that any change in how much they smoke will affect how some psychiatric medications work. This is information that must always be passed on to the doctor. One of the most important tasks of a caregiver is learning to recognize so-called red flags, symptoms that must never be ignored. Medical literature most often lists sudden worsening of breathing, chest pain, balance disturbances, numbness on one side of the body, severe dehydration, loss of consciousness, seizure-like symptoms, sudden delusions with a sense of threat, complete insomnia lasting several days, and suicidal thoughts. You do not have to decide whether this is schizophrenia or a physical illness. In such situations, you must always seek urgent medical help, both physical and psychiatric. Your support is not limited to reacting to danger. In everyday life, it is just as important to create a safe atmosphere, keep communication open, and calmly talk through problems. The person often cannot describe their symptoms clearly and sometimes does not notice them at all. If you are able to notice a change in behavior and gently bring it up, this can completely alter the course of the illness. In clinical practice, we often see that it is the caregiver's calm approach and systematic observation that prevent crisis situations which, without that support, would have ended in hospitalization. Caring for someone with schizophrenia requires patience and vigilance, but also great attentiveness to physical health. Co-occurring illnesses do not appear in a vacuum. They always alter the picture of schizophrenia and the person's functioning. If you understand these interconnections and can act early and decisively, you become the one who protects your loved one from more serious complications. Summary: when you see schizophrenia only as a mental disorder, it is easy to overlook the entire network of factors that actually determine the person's health and quality of life. Today's medical knowledge clearly shows that schizophrenia does not concern only thoughts, emotions, and behavior. It is a disorder that affects how the whole organism functions and interacts with many other illnesses, whether they are mental, metabolic, neurological, or cardiovascular in nature. This is why clinical literature increasingly refers to schizophrenia as a systemic illness, one that demands as much care for the body as for the mind. Co-occurring illnesses are not an add-on to schizophrenia or something secondary. They form the real context in which the illness manifests. Metabolic side effects of medications change how the person functions every single day. Anxiety and depression overlap with negative symptoms and can completely alter the picture of the illness. Neurological diseases can look like a worsening mental state, and heart disease, like growing tension or confusion. When you don't understand these interconnections, the whole picture can seem chaotic. When you begin to see them, order and understanding appear. Your role as a caregiver is unique because you see something no doctor sees: everyday life. You see small changes in behavior, walking speed, appetite, energy, medication responses, sleep quality, manner of speaking, and even subtle signals the person cannot put into words. The doctor sees the patient for a few minutes. You see them in life, and life is where real diagnosis happens. For this reason, clinical literature consistently emphasizes that effective care requires cooperation between the psychiatrist, the family doctor, other specialists, and you. Understanding co-occurring illnesses helps you better distinguish what is a symptom of schizophrenia from what stems from treatment, lifestyle, or a condition unrelated to psychiatry. Thanks to this, you react faster, support more wisely, and more effectively protect the person from crises. Schizophrenia is never an isolated illness. It is always embedded in a broader context of physical health, relationships, stress, environment, and metabolism. When you look at it this way, your help becomes not only emotional support, but also a real part of treatment.